Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question of dermatology. A 25-year-old male presents with extensive patches of altered pigmentation on his front, back, face, and thighs. There is mild pruritus. A diagnosis of extensive Pityriasis Versicolor is made. What is the most appropriate management? A. Oral metronidazole. B. Topical terbinafine. C. Oral ketoconazole. D. Topical selenium sulfide. And E. Oral terbinafine. Okay, here we have a 25-year-old man coming with extensive patches of altered pigmentation on his front, back, face, and thighs with the diagnosis of extensive Pityriasis Versicolor. And the question is asking about the most appropriate management. The most appropriate management in extensive Pityriasis Versicolor is oral antifungals like oral ketoconazole or systemic ketoconazole. Okay, here we are going to explain it. Explanation: given the extensive nature of the lesions, systemic therapy is indicated in these cases. Pityriasis versicolor. Pityriasis versicolor, also called Tinea Versicolor, is a common superficial fungal infection of the skin caused by the overgrowth of Malassezia species, lipophilic yeasts that are part of normal skin flora. It is characterized by hypopigmented, hyperpigmented, or erythematous scaly patches on the trunk, most common and proximal limbs. Etiology and pathogenesis. Causative organisms: Malassezia furfur, Malassezia globosa, and Malassezia sympodialis are commensal yeasts. Predisposing factors: hot and humid climate, which is common in tropics, oily skin, sweating, use of oily creams, immunosuppression like HIV patients, and corticosteroid use, diabetes, occur in healthy individuals, malnutrition, and Cushing's syndrome are predisposing factors of Pityriasis versicolor. The yeast transforms into its pathogenic mycelia or hyphal form, leading to skin change. Pigmentary changes occur because Malassezia produces azelaic acid, which inhibits melanocyte function and in its turn leads to hypopigmentation in some, and inflammatory response causes hyperpigmentation in some patients. Clinical features: lesions: multiple well-demarcated oval or round patches with fine, browny or powdery scaling. Color: as we said, hypopigmented is most common, hyperpigmented, pink, brown, or erythematous. That's why it's called versicolor or variable in color. It may be more noticeable following a sun turn. As we can see here, we can see the lesions of hypopigmentation or the Pityriasis versicolor in the back of this patient. Here we can see also the oval shape or the round shape, well-demarcated lesions of Pityriasis versicolor of the chest of this patient. Here also we can see the hypopigmented lesions of Pityriasis versicolor, and here we can see the hyperpigmented lesions or erythematous lesions of Pityriasis versicolor in the back of this patient. Okay, also here we can see the round, well-demarcated lesions of Pityriasis versicolor, and the lesions are hypopigmented. Distribution: upper trunk, more common, chest, back, shoulders, upper arms, and neck. Rarely, Pityriasis versicolor involves the face, and this one is common in children. Symptoms: usually asymptomatic but mild itching and pruritus in some patients, especially with sweating, can be present. Sign: when the lesion is scrubbed, fine scales become more visible, which is called a scratch sign or Cope dongle sign. As we can see here we can see some Pityriasis versicolor lesions, but after scratching the lesions become more prominent, and this one is called a scratch sign or Cope dongle sign. Diagnosis: Clinical appearance is often diagnostic, and Wood's lab, we can see yellow-green fluorescence under Wood's lab, and KOH preparation or skin scrapings shows the characteristic spaghetti and meatball appearance, which is the hypha and yeast cells. Differential diagnosis: vitiligo, psoriasis, alba, seborrheic dermatitis, and post-inflammatory hypopigmentation are differential diagnosis of Pityriasis Versicolor. Treatment of Pityriasis Versicolor. Topical therapy is first line in limited lesions like selenium sulfide 2.5% lotion and shampoo applied to affected area and washed off after 10 to 15 minutes daily for 1 week, then weekly. Ketoconazole shampoo 2% leave on for 5 to 10 minutes daily for 5 to 7 days, and topical antifungals like imidazole, topical antifungals include imidazoles like crotonamazole and miconazole, and also terbinafine are useful. Systemic therapy for extensive recurrent cases. Systemic therapy is needed. Itraconazole 200 mg daily for 5 to 7 days, and fluconazole 300 mg once weekly for 2 to 3 weeks is indicated. Note: oral terbinafine is not effective because Malassezia is resistant to oral terbinafine. In limited lesions, topical terbinafine can be helpful, but in extensive lesions, oral terbinafine or systemic terbinafine is not effective on Malassezia yeast, and this is a very important note because Malassezia is resistant to oral terbinafine. Prognosis usually is excellent with treatment, and recurrence is common up to 60%, especially in warm and humid climates. Hypopigmented patches may persist for weeks to months after treatment because pigment takes time to return, and this is important, and we must say to patients, they complain sometimes that they are taking the therapy but the lesions are remained. We must say that pigment takes time to return. Okay, this was a short explanation about Pityriasis Versicolor presentation and management. Thank you for your attention.